I think our first two speakers very ably teed up what we're to do the rest of the day and a half. They gave us a lot of material, a lot of historical background, which got us to where we are, our current scene and the level of complexity that's facing all of us, and how we begin to think about the future of healthcare reform in the United States. And it's a deadly serious business, and it's going to take everybody in their efforts to do so. Our next panel will begin to flesh out some of those ideas and issues that we're facing today. First, though, I'd like to introduce Kevin Malone, who will be moderating this panel. Kevin is an analyst in the Administrator's Office of Policy, Planning, and Innovation at the Substance Abuse and Mental Health Services Administration, SAMHSA, in the Department of Health and Human Services. Kevin works primarily on the implementation of health reform. Kevin leads SAMHSA's work on outreach, eligibility, determination, enrollment, and recertification in response to the planned expansions of eligibility for coverage affordability in 2014. Kevin also is manager of SAMHSA's Center for Financing Reform and Innovation, a national financing analytics and technical assistance project. That's quite an agenda, Kevin. Indeed. Let me welcome Kevin to the lectern.
All right. Good afternoon, everyone. Thank you very much, Tom, and thank you so much, Mrs. Carter and the Carter Center, for welcoming me and the rest of the panel to speak with you today. I also want to thank everyone for the opportunity to serve on the Planning Committee. Having come close upon my own 29th birthday next month, it is it's an incredible honor for me in my young career to have the opportunity to participate in something as important as this event, and the contributions that the people who are here have made to the field is something I aspire to in my career, so it's an incredible honor to be here with you all today. We're going to be speaking today about something that on its face is not necessarily considered mental health or substance abuse treatment policy. It really is about access in its most basic form. We heard from Joel just now how at the end of the day it really does start with enrollment. If we don't get people into coverage, get people into the coverage that works for them and their family, the rest of the conversations we'll be having over the next day and a half about improving the quality of care, the coordination of care, and improving the public health of our nation are really predicated on this first small step. And what we're hoping to do with this forum, what we talked about as a team, what seems like a year ago, was really digging into the substantive policy issues that do underlie how people are found eligible for coverage, apply for it, enroll into coverage, choose between the coverage options that are presented to them, and start accessing care. And I have to say that the terminology, the jargon, is something that is new to many people in the mental health care system for many reasons. I have had the misfortune of having to train many people across the country on eligibility policy, and for some strange reason, nothing makes mental health professionals fall asleep faster than the phrase income calculation methodology. I don't know what that says about people who work in mental health, but the expansion in coverage, I think, and the importance and significance for public health and even for individual rights, I think was really eloquently addressed by our previous speaker. But one thing I do want to address is that there has been improvements in the past about getting people into coverage. There have been case-by-case expansions in eligibility. But the Affordable Care Act is a leap in comparison to all of those things. It's not perfect. There will obviously be people who are unable to access care, both because of non-expansion and also because of failures in the system that we'll be discussing today. And that's really why we thought that this warranted its own panel discussion with everyone, because we think that as mental health policy professionals, this is a space we need to own and we need to understand as something we can work on. In particular, if in states where we have expanded coverage early, we've seen that when there aren't really targeted efforts to reach people with mental illness or substance use disorders, they don't enroll at the same rates as persons without those conditions. And coverage continuity remains a significant problem for people who do access care, with significant issues with regards to accessing quality data about those people, and certainly their own access to the medications and services that they need if they are avoidably disenrolled. So we have put together a panel today that will really, I hope, open up and open up your thinking about some of the thornier policy issues that actually underlie how we can go about getting people enrolled, how we can go about effectively and meaningfully utilizing our energies as a community, because the time is right now. We may not have to spend our energies thinking about income calculation methodologies for the next decade, but we do right now, because open enrollment is happening right now, and if we don't act right now, this chance will pass us by and we will be leaving people out in the cold. So the panelists that we have the incredible privilege of hearing from today have some of the greatest expertise in the country on these issues. And I really, it's a pleasure for me to have the opportunity to introduce them. First off, we'll hear from Jessica Kendall, who is the Director of Outreach at Enroll America. I'm sure many of you have heard of Enroll America. They have been an incredible partner to us at SAMHSA in our efforts on outreach and enrollment. And there has never been a time when they have not said yes to a request to come help. And today is just another example of that. Enroll America, if you haven't heard of it, is a nonprofit, nonpartisan organization whose mission is to ensure that all Americans are enrolled in and retain health coverage. Prior to joining Enroll America, Mrs. Kendall consulted on consumer assistance and navigator-related projects and served as the outreach manager for Oregon's Healthy Kids program. In addition, we're very lucky to have Dr. Hepburn. Dr. Brian Hepburn is the executive director of the Maryland Mental Hygiene Administration. I've been mentioning already many times today how fortunate we are at SAMHSA to have Dr. Hepburn right down the road, and we depend on him time and time again for help as we try and support senior state officials on thorny policy issues, and it's an honor to be on a panel with him today. He's served at the Mental Hygiene Administration since 1987 in roles including clinical director and the director of psychiatric education and training. And it's wonderful to have him on our panel today. In addition, we have Dr. Liz Baxter, who's currently the executive director of We Can Do Better, founded in late 2005, originally as the Archimedes movement. And she is at the forefront of an effort in Oregon really trying to leverage the effects and the opportunities and the experimentation that they're doing there to make sure it's not only successful in Oregon, but that the rest of us take notice and follow their lead. So I'm excited to hear from her and let her share some of that experience with us as we plan what we're going to do in the next day and a half. And finally, we're extremely lucky to have Patricia Taylor McManus, who's the co-founder and president and CEO of the Black Health Coalition of Wisconsin, which is a community-based advocacy organization. She consults locally and nationally on health issues related to cultural competence, systems change, and resiliency. So as you can see from our panel, it includes experts on national outreach, enrollment assistance, communication, eligibility, application policy, as well as at the state, community, and local level. Because in this issue in particular, all of us can do something today to make a difference in getting people enrolled in coverage, either in our roles as a national leader, as state leaders, or as leaders in our community. So without further ado, I'm happy to turn things over to Ms. Kendall.
Good afternoon, everyone. Thank you so much for having me. Thank you to the Carter Center and to Mrs. Carter. How many folks in here are familiar with Enroll America? Okay. Well, clearly we've been doing a lot of work over the last couple of years. I do want to provide you with a little bit of an overview of who we are, what we're doing, and then really what we're seeing nationally, statewide, and locally to provide the stage for how I can see all of you participating and really making sure that we reach out to consumers. So as it was just mentioned, we are a national organization. We are nonpartisan and nonprofit. And I think the key thing to us is we have a very narrow mission. And our mission is to make sure that Americans get enrolled into health coverage that's been provided through the Affordable Care Act. Now, we're going about that in a couple of different ways. The first way is promoting best practices. So what have we learned in the past? What have we learned from other public coverage programs? What's worked? What barriers have kept people out? And how can we learn from those experiences to make sure we can get as many people enrolled as possible? And then the second way is we have a national campaign called the Get Covered America campaign, which I'll talk about in just a moment. But really the goal is to make sure that we're reaching consumers. We truly believe this is going to need to be an all-hands-on-deck effort. So to us, what that looks like is partnering with as many types of stakeholders as possible. And a stakeholder to us is anybody under the sun who has a vested interest in making sure that Americans get enrolled into health coverage. So we've partnered with NAMI, Mental Health America. We partner very closely with SAMHSA. We also partner with health insurers, health systems, pharmaceutical companies, advocacy organizations, retailers, businesses, labor unions, disease-related groups. I think it's important to mention because when you put our partners in a room together, they do not get along, but they all agree that getting people enrolled into coverage is essential. So the way that we're going about doing this is creating this National Get Covered America campaign where we're making sure to tap into those strategic partners, which is really where all of you come in. So we want to make sure that we are looking for who are the folks that influence the uninsured, right? They are all turning to somebody. They're turning to somebody in their community for resources, for a job, for housing support. They're turning to a health center. They're turning to a faith-based organization. People in this country are connected somehow to other people, and we want to make sure that we're building those connections and making sure those uninsured consumers get the message that coverage is available. We also want to make sure this is a neighbors talking to neighbors campaign. So I understand only 10% of you are probably listening right now. There's going to be some key parts that I want everybody to listen to, but what I want you to think about is as thought leaders, what is your role not just in your organization, but in your community, right? In the world that you exist, do you have children? Do you have grandkids? Do you have a community that are going to look to you for information? And how can you spread the word that coverage is available? We're very data and results driven. We want to make sure that we're continually evaluating our effort to be successful and to modify our work that we're doing on the ground. If it's not working, we want to change it. What messages resonate with consumers and how can we be using those messages to be more effective? We are using earned media, paid media, social media, and then we're also looking for surrogates. And what that means is who are people in your community turning to for information? And how can those people become the messengers of the fact that coverage is available? Because it will be essential for all of those thought leaders, all of those trusted messengers to be coming forward and saying that coverage is available. So nationally, what we're doing is we have staff on the ground in a handful of states. Those are the states that you see in dark blue. Now, light blue is the rest of the country where there's activity happening all over the place. But what we want to do is pull together coalitions or tap into pre-existing coalitions that look somewhat like our national partnerships. Because again, in order to have all hands on deck to really make sure that we're reaching everybody, it will be essential in all of these different states for people to come together in Oregon, in Wisconsin, in Maryland to say, what are we doing? Where are the uninsured? And how can we reach them? And how can we coordinate those efforts rather than complicate them in order to make sure we're reaching as many people as possible? So you may notice some similarities here. If you look at the map of the country where you see the dark red, that also happens to be where there's the highest number of uninsured in the country. So in 10 of those states, I'm excluding California and New York for a variety of reasons. So in 10 of those states, we do have staff on the ground. Those are the states that have the highest number of uninsured and also have the least likely chance of having a campaign set in their state. For example, Texas, right? You have over 6 million uninsured consumers in Texas, but you don't have millions of dollars being put into a campaign like you see in a place like California to move the message that coverage is available. But if you look at a state like Idaho, nearly 20% of the adult population doesn't have health coverage. So it will have just as huge of an impact getting those 20% in Idaho, getting them health coverage, as it will to get the 6 million health coverage in Texas. So it's not just the number of uninsured that we care about, it's also the rate of uninsured in your state. Now, I want to bring it way down. I've been told you guys are a very high-level audience, but I'm going to bring it down to the consumer's perspective really quickly and try to talk through what is that consumer experience. So we know that from a consumer's perspective, this is supposed to be a seamless process. And I really want to focus on the vision, not the reality right now. The goal in life for me is fighting for that vision because I think that's what gives us hope. Right? So where we are today is not where we were a year ago, and where we are going to be a year from now is not where we are today. So that vision is that a consumer should be able to go online, pick up the phone, or fill out a paper application, and have a single streamlined process where they don't need to know any of the weedy, wonky, behind-the-scenes details of what happens to their application. If I'm a pregnant woman, I may go into Medicaid, my husband may go into the exchange, and my child may go into CHIP, and it really doesn't matter because I know that for the first time I can get health coverage. But from a consumer's perspective, they probably haven't heard about any of this. And if they have, they've probably heard that things aren't really working and they're not really sure what they should be doing right now. So to do a deeper dive, to take that step, and I know that the secretary may be speaking about this tomorrow, is where are we actually at? This has been incredibly frustrating for a number of people when looking at healthcare.gov because they haven't been making it through the system. But I actually think that there's a number of success stories that have happened so far. Liz may touch on this in just a moment, but Oregon already has reduced the number of uninsured by 10%. Arkansas has reduced the number of uninsured by 14%. Over 32,000 people have been enrolled into coverage in Kentucky, and in Washington state, over 50,000 people have applied, a majority of them going into Medicaid. So we have success stories around the country of people actually applying and getting through. For healthcare.gov, over 700,000 people have actually created accounts, and thousands of them have been able to make it through the system so far. But I think that we always can do better. And part of my concern with all of the talk that's happening right now about the problems we see today or the problems we saw last week, and I'm sure we're going to see next week, is that they serve to reinforce people's preconceived notion that there's not a program available for them, that there's not a place that they can go for help, and this actually doesn't apply to them. So I've actually been hearing from a group of folks called Certified Application Counselors, which I'll talk about in a moment, who said, healthcare.gov doesn't work, therefore I'm not helping anybody and I'm turning them away. Well, there's actually a lot of ways that you can make it through the system, right? You can use the call center, you can fill out a paper application, or there's times throughout the day where people are making it through healthcare.gov. But I think what we need to think about is whether or not people will actually even know to apply. So yes, this week there are administrative barriers to getting through the system. But Enroll America did a national survey about a year ago, and we looked at who are the uninsured, what do they know about health coverage, and what do they need to know in order to want to apply. And a year ago, what we found is that 78% of people had no idea that coverage would be available to them. 83% of those that would be eligible for Medicaid had no idea. So a Kaiser survey that took place in August saw that we did see a change in those numbers, that we got to 43%. However, that's nearly 50% of the population that has no idea that they can apply for coverage. And I think as we think about all of the ways that we can improve the system and all of the ways that we can improve access to care and actually improve the type of care people are receiving, the thing I want us all to digest is those are great conversations to have, but you're not going to apply for a program you don't know about. And that's baseline, right? People are not going to apply for this. Even with these great numbers, we have over 40 million uninsured Americans. And what we know from other public coverage programs, like Medicaid and CHIP, where you've had a ton of money dumped into or put into getting people enrolled in coverage, about 84% of those eligible are enrolled. For SNAP or for food stamps, 54 to 71% of people who are eligible for food stamps has actually got enrolled. So starting at the beginning, from that consumer's perspective of making sure they know about the coverage options that are available, where they can go to apply, that's what's going to be essential. And I had no idea these colors would be so bright on that screen, so I do apologize. But I want to really highlight that it's about making sure that people know that coverage is available, and then most importantly, keeping them in. Because we know that there's a lot of opportunities out there, that people will be benefiting from this. But what we also know is that they're a whole lot more likely, the communities that we all interact with, they're a whole lot more likely to either be hard to reach and not make it through the system to begin with, or if you do reach them and they do apply for coverage, to not know how to use it, and then to end up not reapplying or staying in the system. So it's not just about finding them, it's about keeping them enrolled. So here's what we also found. With our national survey, looking at who are consumers, what do they need to know, we took all of our information, we compared it to all of the other research that had been done up until this past January, national surveys and state data. And we found that people overwhelmingly want health coverage. They want it. They just feel like they cannot afford it. And if they can afford it, it's not a very good coverage option for them because they've had experience with health insurance in the past. It's difficult to navigate, it's overwhelming, it's expensive, and there's a lot of fine print. So taking that step forward and letting people know that coverage is available, that will meet all of their needs, it will cover all of the care they need, like hospitalizations and mental health and substance use disorder services and prescriptions, and that they can get financial help. This is what gets people to that place of being able to apply for coverage. Now, if I only have 4 things you are going to take away from this whole conference, or specifically from this, it's these 4 facts, because whatever type of organization you work for, if you are an academic, if you are a CEO or a CFO, or if you happen to work for a foundation, start thinking about how you can take these 4 messages that coverage is available and inserting them into the work that your folks are already doing. This is what consumers need to know. All of the policy discussions that are essential that we're all having actually don't reach consumers, and they don't make any sense to consumers either. So think about, how do you move those 4 messages, and then how do you connect consumers to help? Now, I imagine for the folks in this room, as thought leaders, you probably lead organizations that work with organizations that potentially have access to consumers. Some of you may be a lot closer on the ground than that. But the information they need to know is where people can go for help, how they can get that application assistance, and there are people in all of your communities that provide application assistance. Now, on the bottom bubbles down there are the folks that already exist. Those top level those squares, those are the new categories through the Affordable Care Act. And that middle one, certified application counselors, is an opportunity for people around the country to actually be able to provide application assistance, to get trained. And now imagine all of the caseworkers and social workers and the folks who are working in health centers and the folks that have access to consumers. They need to know those messages, and if they want to do application assistance, there is a venue for them to get trained and to go help people apply for coverage. Now, if that doesn't fit with the work that your staff was doing, or the staff the work that your partners are doing, you can still train them on those messages. You can send those messages out through newsletters. If you have people that are calling your organization and you happen to have beautiful music playing for me to listen to, you can put a message on your voicemail or that on hold message that says, go to healthcare.gov and apply. Coverage is now available. There's so much that you all can do, but the key thing is making sure that you move that message to your community, to your network, to the folks that you work with, to make sure that it reaches consumers that coverage is available. Thank you.
All right. Thank you very much, Jessica. Next, I think we can have Dr. Hepburn take the mic.
Thank you very much. It's a pleasure to be here. Thank you, Mrs. Carter. Thank you to the Carter staff and the Carter planning people. Looks like you've set up a 2-day event that is going to be very exciting. I'm very proud to be from Maryland. Why am I proud to be from Maryland? Steve Sharfstein, for one. And I got to see Steve Sharfstein, the younger Steve Sharfstein. I thought, who the hell is that? It was Steve. I thought it was one of the Kennedys. Howard Goldman is here. We're very blessed in Maryland to have a lot of support and have people who are very much interested in making public health, but specifically public mental health, better. The leader over the last 7 years has been Governor O'Malley. We've been very fortunate. Governor O'Malley has supported mental health first aid, suicide prevention, crisis services. He, during a time when many states cut back on the public system, he expanded the public system. We're also fortunate we have another Sharfstein. Josh Sharfstein is our health secretary. Looks a lot like Steve. Chuck Milligan is our director of Medicaid, one of the best Medicaid directors in the country. Fantastic to have him at this time. And our leader in public behavioral health is Gail Jordan Randolph. So not only do we have support from the executive branch, but we also have support from the legislature. So while we hear of the difficulties in many states, Maryland is unique. We don't have those difficulties. And we're not looking for them. So. When the Affordable Care Act was first established, the governor set up a council, a Health Care Reform Coordinating Council. And it went very quickly to try and make sure that Maryland was one of the top states, one of the quickest states to move ahead with the Affordable Care Act. One of the things they worked on was the essential health benefits. I bring this up because for most of the exchange, the decision was made for the companies to use the small group plan. This was not the decision that was made for behavioral health. It was felt that for behavioral health, the small group plan was not adequate, that it did not meet parity. So a decision was made to use the Government Employees Health Association plan, which was a much broader plan and did meet parity. Parity is very important in Maryland, but I want to point out that the group that is taking the lead on parity is the Mental Health Association. And that's to highlight how important stakeholders are and stakeholder groups are in Maryland. The Maryland Parity Project basically is set up to educate Marylanders to make sure that they know what their rights are under parity. It has two main goals: educating consumers and providers of their rights under the parity law and offering case assistance to those whose rights may have been violated. One of the other things that the Coordinating Council set up was the Health Connection, which went into effect October 1. The goal was to allow individuals to make insurance company comparisons and determine eligibility for financial assistance to reduce the cost of monthly insurance premiums. What was set up was a single streamlined application that would be used to determine eligibility for Medicaid or for the exchange. Consumer assistance was available through the call center or in person throughout the state in local health departments, departments of social services, and a network of consumer assistance organizations called connector entities. An update, this is from October 25th. I actually have a more recent update. 350,000 unique visitors, 44,000 calls to the call center, 46,000 households created accounts, 31,000 found out if they were eligible for financial assistance, 4,500 were enrolled. Now, one of the things that Medicaid did in Maryland starting in 2006 is that they moved ahead with a demonstration project called the Primary Adult Care Waiver. It was for individuals over 19 who met financial eligibility for Medicaid. Within that group, there are about 82,000 that will move to Medicaid effective January 1. This group is important because it is essentially looks like the group that in the late 90s lost their entitlements because of the decision that individuals with substance abuse problems, if they had entitlements, that would just contribute to their difficulties and make it harder for them to stop being addicts, so they lost their entitlements. This new group looks very similar to to that group, and very similar to what we think the Medicaid expansion will look like. Partners for moving ahead with the Affordable Care Act. We're very fortunate in Maryland. We've got SAMHSA there. We've got CMS there. Now, do they give us special privileges? No. But most of them do live in Maryland. Most of the people who work there do live in Maryland, so hopefully they look at us in a positive way. We love SAMHSA. We love CMS. We look forward to all the good things that we can do together. In addition, NASDAD, the National Association of State Mental of Medicaid Directors as well, have all been very helpful to us. Joel put together a resource management guide while he was at NASHBID. That's the National Association of State Mental Health Program Directors. And that's a nice guide because it's available on the web. It's for each individual state, and as Joel mentioned earlier, it looks at the current Medicaid program, the new state Medicaid comparison, the new state Medicaid expansion program, and the exchanges. It looks at the percentage and number of uninsured people aged 18 to 64 eligible for coverage under the 3 health insurance options and that are displayed comparing individuals with serious mental illness, serious psychological distress, and substance use disorder. It's a really nice tool for states to have. I'm not sure how many states are aware of this tool. It is a very nice tool. In Maryland, we've used this tool, but also we have very good data from our system. We use claims data, and we use our outcomes measurement system data. In the current public mental health system in Maryland, we have 150,000 individuals who are receiving services, a 50% increase over the last 5 years. Stakeholders are very important in Maryland. We have a consumer organization on our own that's been around for 30 years. Family members are very important. Providers are very important. We try to make decisions as a community. The stakeholders are part of that community. We have a strong university-state collaboration. We work on a regular basis with Howard Goldman and his group. We have a strong private-state collaboration. We work regularly with Steve Sharfstein and his group. The Mental Hygiene Administration and Core Service Agency oversee an administrative service organization model for Medicaid, individuals with Medicaid, and individuals who are uninsured. One of the areas that has really helped us over the years to prepare for what we're doing now with Medicaid expansion is that we have made it a prerequisite for the uninsured. In order to get services within our system, there has to be proof that they have applied for entitlements. Our goal has been to try and get as many people entitlements as possible. We have, over the years, provided the public mental health services, the substance abuse services, but that doesn't help individuals who also need physical health care. So we have really tried hard to get individuals on entitlements, and that has set us up very well going into the next step with the Affordable Care Act. We obviously also have contracts for services for non-Medicaid recipients and also for Medicaid recipients for services that go beyond the Medicaid services but are needed for recovery. Our claims data, we started in 1997. We get quarterly reports. The claims data gives us an idea of the population that we're working with and the services that are being used. One of the things I wanted to point out was our penetration chart. What that shows is the historical penetration, and even though, as I said, we've expanded over the last 5 years by 50%, you can look at the penetration and it is historically consistent. So that in 2013, if you look at the child penetration rate, it's about 9.5%, the same as it was for 2012. It's actually higher than it was in 2011. And the adult penetration is 16.5%. So that has been historically consistent. That helps us with Medicaid expansion because if Medicaid expands by 100,000, we know our penetration let's say it's all adults, will be close to 17%, so that out of that 100,000, about 17,000 individuals will need services. One of the areas that we're very proud of, and Howard Goldman and his team, Value Options, and the Mental Hygiene Administration put together, was a measurement system. Our outcomes measurement system is very good. I encourage you to go take a look at it, play with it. For people who like to play with data, it's a really nice setup. And the Data Mart website is identified there. I'm going to show you a screenshot. This screenshot basically is of the psychiatric symptoms, and you can see that the progress has been consistent. There's been improvement for depression, for relationships, for self-harm, for emotional lability, for psychosis, for substance abuse. There has been consistent improvement between the first time the person was seen and the last time they've been seen. So we use our data in order to help us to predict what services people will need. Now, previously I identified to you the primary adult care population, and that seems to be different than the traditional Medicaid population. So we've done some comparisons. One of the comparisons was in the area of substance use. So our non-PAC population, that is our traditional Medicaid population, the substance use is about 17.3%. For our PAC population, it's 31.5%. That ends up being very important as we predict what will happen with the expansion, because we think the expansion is going to be similar to the PAC population. So if you're comparing the two, the PAC population has a higher percentage of individuals with co-occurring substance use. In addition, they seem to have a mild to moderate mental illness rather than a severe mental illness as a group. They have a higher need for housing, for legal help, and for employment. In addition, about 75% smoke as compared to the traditional MA population, which is closer to 50%. Both are very high. Smoking cessation is very important for both, but for that population that has a 75%, they're going to have a higher comorbidity for physical health problems. Maryland will also conduct outreach to more specific populations. We have a homeless ID project. As you all know, when you go and work with people who are homeless, they usually aren't carrying documents with them that you can use in order to get them entitlements. So this homeless ID project, which is supported by the governor and state funding, is to get the documentation for the homeless that will then help them to get the entitlements. We also have a SOAR project, PATH project that you're all familiar with in your states because these are federal projects. We also focus on jails, prisons, and hospitals in order to get those individuals on Medicaid. So to summarize, right on zero. To summarize, Maryland is moving ahead. We are proud of what we're doing. We want to increase outreach. We want to be #1 in the country for the Affordable Care Act. We want to make sure that we do not have people who are uninsured. We want to make sure that we have as high a quality system as possible. We support health care reform, and we support the Affordable Care Act. Thank you very much.
Thank you very much, Dr. Hepburn, for those rousing remarks. I think we all are grateful. I wish I should move from D.C. to Maryland now. Ms. Baxter, I think the floor is yours.
You could move to Oregon, that's okay. So, in the spirit of full disclosure, I have to tell you a story before I start with my slides. Number one of the things that Kevin didn't mention is that I also chair the board of directors for our state's health insurance exchange. So just in case anybody wants to throw things at me, you can. But secondly, that I also have just kind of transitioned from We Can Do Better to the Oregon Public Health Institute, hence the title up there. but I still have lots of strings attaching me. And then the third thing, I'm going to tell you a story about one of my boys. So I've raised 3 boys into adulthood, and poor Jessica doesn't have to hear the story again, but I was transporting, 5 sweaty soccer-playing boys in a car when we drove by the Powerball sign that said, the next Powerball is $345 million. And so I got to listen to 5 teenagers talk about what they would do with $345 million. And my son says, and he's probably 14, well, just hope that my mom doesn't win that Powerball, because if she does, she's giving all the money away to poor people. And so without skipping a beat, one of his friends says, so what does your mom do? And he says, my mom is a nurse and she works at a hospital. So Kevin, I have to tell you, I'm not a doctor. And so I get home and I say to Tyler, why did you tell your friends that I'm a nurse and I work at a hospital? And he said, because it's so much easier than trying to tell people what you do. So just want to say I'm not a doctor in case anybody passes out and they're looking for a doctor, go there. I feel like I'm going to give you about a 7-minute flyby introduction to Oregon and how we have approached setting up our marketplace, which is still a hard term for me to use. And in order to understand Oregon, you need to understand everything else that's happening in Oregon. And so one of the things that We Can Do Better did over about a 7-ish year period is that we actually made a point in working with many community partners to go around the state, starting in 2007, to see if we could actually get agreement around the state on a set of governing principles that should guide our efforts around health reform. And what that led to in 2009 and in 2011 was an agreement among our policymakers, decision makers, and legislators that it actually didn't matter to us what the bill was called, what the bill number was, who introduced the bill, that there were some certain things that we wanted to accomplish with our efforts around health reform. So at a time when other states were not able to move, when other states were at gridlock, Oregon was able to pass fairly significant health reform legislation with strong bipartisan support in both 2009 and 2011. And I think that that just is, if nothing else, what can happen when you do things from the ground up as well as from the top down. So just want to start there. Whoops, going the wrong way. So my first message to you, most of the people that you work with could not tell you what the difference is between these 3 terms. They use them interchangeably. They think they mean the same thing. They are all getting to this point that folks want an answer to this question. When X is happening to me, who do I call and how am I going to get help? And they will tell you it's healthcare, health insurance, getting me to better health. They don't know the difference, but you do know the difference. Sorry, I'm going to keep going the other way. The second thing is that, and there's actually this wonderful picture from during the FDR administration about what happened through the New Deal, the alphabet soup that was created because of reform. And so what people in Oregon are hearing, all of these letters being tossed out at them, all of the different changes that are occurring. And again, remember what they want to know, who do I call when something is happening to me or my family, how am I going to get help? And we're giving them just a whole new lexicon of how they're going to maneuver through this. So here was the approach that Oregon agreed to back in 2007. This is from work with Don Berwick and the Institute for Healthcare Improvement. Oregon adopted the triple aim. They did that fairly low key to begin with, but by 2009, our newly created Oregon Health Authority incorporated the triple aim. When we created the Oregon Health Insurance Exchange, we incorporated the triple aim, and all of the work that's happening on the ground is using this language. Those are our 3 objectives. We want to do those simultaneously, and in order to do that, it's going to take all of us working together. But we're also fairly, I don't want to say we're a poor state, but we're a state that struggles economically and probably have been struggling like many states for the last 10 to 15 years. And this has been our standard approach when we have had trouble economically. You cut reimbursement to providers, you cut services that are available, or you cut people. And so with this, having the triple aim in mind, this was what we said we needed to focus on. There was a different set of strategies that we needed to take into account, because if we were going to get to better health at a lower cost with a better experience of care, we could not use those 3 traditional strategies. And then we had this as one of the tenets that was just known to us. Half of the babies born in Oregon on the Oregon Health Plan. That's our Medicaid program. 16% of Oregonians, which kind of matches where we've been around our uninsurance rate, on the Oregon Health Plan. 85% of our providers, 11% and growing of our state budget, and 40% of the people on the Oregon Health Plan are people of color, which is not the percentage of the people in Oregon. So we knew that what we had was both some pretty staggering numbers and a great opportunity. That is the context within which we created our insurance exchange, which is called Cover Oregon. So we're a public corporation. We have a 9-member board that is appointed by the governor, approved by the Oregon legislature. And we said within the Affordable Care Act, as we're doing this work in Oregon, we wanted to have all of the other work that's happening in Oregon as our template to go on. And of our mission, there's nothing about it that's surprising except for the first 5 or 6 words. And for those of you who have sat through a mission crafting exercise, which is always fun, we struggled on 2 pieces. Improving the health of Oregonians, was that part of the mission of a health insurance exchange? And did we include the word all, knowing that not all Oregonians were coming through the health insurance exchange? Our board said both of those things are important for us to remember the context within which our health insurance exchange is operating. This one I'm probably going to pass, but knowing that you may have access to it, it's really just the new paradigm that we're working within, all the changes because of the Affordable Care Act, the essential health benefit items that are included. Those are all things, if there's a piece that I could wish away, it was that every state would create an essential health benefit. I wish we just had one across the country. But this is the place that has caused us the most excitement and opportunity and the greatest challenges. Because we decided that we wanted it to be simple for Oregonians. So we wanted one door. And that meant it was one door for people getting commercial coverage or getting Medicaid. It was going to be one door if you were getting that premium subsidy or you weren't. It would be one door if you were in the individual market or in the small employer market. We said we wanted to have one portal, one door, make it as simple as possible for people to get this coverage. And our focus, ironically, was never on October 1st. Our focus has always been on January 1st. What we knew going in, there were people who could not get coverage on December 31st, but they could get it on January 1st. We wanted to figure out a way that they would be covered on January 1st. And then on top of that, we get a federal waiver to absolutely change the way that we do our delivery system. And we started with people on the Oregon Health Plan, again, because of those numbers. But our plan is it's not just about Medicaid. We're changing the delivery system eventually for every person in the state who gets care in the state of Oregon. So our exchange operating within a much larger purview. And I'm going to skip that one. So I'm going to run you through 3 maps of the United States. And for those who don't know where Oregon is, it's the state right above California on your way to Canada. And right in between California and Washington, I should say. I shouldn't skip Washington because they're important too. So in the Affordable Care Act, the ability to create healthcare co-ops. There were supposed to be, the hope was 1 in every state. There are 24. Oregon, the only state that has 2. So know that our marketplace is different because we have 2 new health plans operating under a totally different mindset and approach than the other health plans that are offered in our exchange. Medicaid expansion. I think I've talked to 3 people so far today where their states are not doing Medicaid expansion. We voted to do Medicaid expansion. We also opted that we were going to do everything in a single portal. As I said earlier, the individual, the small employer, the Medicaid, the subsidies, everything through a single portal. It's possible that we bit off more than we could chew. But the nice thing for us We chose it intentionally eyes wide open because we actually had an objective that we were trying to reach. So that was important for us. This is what I'm hoping that we get to at some point in time, that it's this easy to find health care. Today it is not. And, I often wonder if we were agnostic to the country that we live in, if we actually saw an article that said there are people who cannot get coverage, 50 million. There's about 40 million people who have coverage, but it doesn't cover them for what they need to have covered. That we have 100,000 people that are dying because they don't have coverage. That we have people who are dying because of the way that they get care and how it doesn't intersect and doesn't treat them in the most appropriate way. We might be calling the United Nations. We might be talking about human rights violations. We don't do that because somehow we think that that's part of the way that we do things in this country. I am so honored to be in this audience and be part of this panel and be invited here. One of the hats that I wear is I'm the parent of a young man who has been suffering with chronic mental conditions since he started middle school. In and out of the hospital, in and out of treatment facilities, has struggled with just incredible challenges. And I very rarely sit in a room where there are people who understand what it's like to be a family that is living with mental illness. These are amazing folks with the best of intentions and the best policies and principles at play. But you don't know what it's like till you've been there. And one of the challenges for me in having this panel be focused on the outreach and enrollment is it's not always just about that component, that at other times, my son had two coverages. It was a challenge getting him the care that he needed to get. So I was asked if I was going to help you as you're walking into your groups. I actually have 5 questions for you, so if I can just have like 1 more minute, I'm going to go through my 5 questions. One, I wish that there were more people who understood the mental health system and the behavioral health system who had been part of the work of my board for the last 2 years, as opposed to showing up in September and October of this year. So the medal levels, the bronze, silver, gold, platinum, there's a challenge in the language that we use because we have talked about the under 30 being a catastrophic plan. The bronze level to me, for many people, is a catastrophic plan as well. Because you don't get to use those copays till you've exhausted your deductible. At the silver level, you're using copays prior to meeting your deductible. For people who have chronic mental conditions, that is an incredibly important distinction. I don't know that we've done a great job about that. What happens in transitions of care, critically important. Where the person-centered primary care medical home is, incredibly important. When Oregon opens up its discussion about its essential health benefit, I know that we're going to do a better job at it than we did in the last year, hoping that we actually are able to frame the question in a better way. I'm not sure that we did a good job of saying what that essential health benefit looks like for people who live with mental health and behavioral health issues. And then the notion of targeted outreach, if there's a phrase that I would love to, kind of do away with, it's the notion that there are populations that are hard to reach. I really believe that because of the way that at least we've approached using community partners, folks have natural ways that they go, where they go for help. And I think that if we can do as much as we can to partner with those natural avenues of access, we will find out that people aren't as hard to reach as we might think that they are. Thank you.
Wonderful. Thank you very much, Ms. Baxter, and apologize for my unintentional academic slip there. Dr. McManus.
That's all right. You gave her my Ph.D. That's
yes,
fine.
Yes, I did. I apologize to everybody involved. Thank you. Please.
Thank you. I don't have slides, so you just get to look at my name while I'm talking, okay? Thank you for inviting me to come and speak. See, now I see what my topic is. I was telling everybody, they told me you got to change your slides to 16:9. I'm like, what in the world is that? But I actually figured out how to do it. But then the only thing I had up there was this big question mark on enrollment, okay? Because that's certainly what has been for us The Black Health Coalition, we actually celebrated our 25th year last month. And we're an advocacy organization that gets involved in just about everything. I even think here, I think people give airline tickets for me to leave Wisconsin so I don't cause as much trouble as I do in Wisconsin and go other places and cause trouble. So I always enjoy getting invited places, even if I have to go back to Wisconsin. But the thing I want to say is that one of the things I think when Jessica had referred me, I didn't know that our organization was going to get one of the navigation grants. And that has truly been an unbelievable experience. Getting the grant, working with CMS, working with our state Office of Commissioner of Insurance, and a state that has made it very clear that they're not going to do anything to promote the Affordable Care Act. And that makes it hard. It's interesting hearing from states where people are doing things. But then you just figure out, I always go from plan A to plan B. If that doesn't work, then you do something else. So I think we figured out, and because a lot of things have been talked about in terms of looking at enrollment and outreach, you have to know the populations that you're going to go and work with. Sometimes you may not, because nobody knows everything, but that's an assumption that you have to have going in, not that you know how to tell everybody, and even how people, as Liz says, look at information and relate to information. And I'll give you one example. Milwaukee, where I am, is pretty much the only wide urban area that's in Wisconsin. Wisconsin's pretty much a rural white state. The capital, Madison, you either work for the state or you go to university. Not a whole lot of other folks don't live there. So Milwaukee is really kind of it's kind of ground zero for a lot of the things that have been going on. But when this issue came up and the money started floating around to help people go on outreach, they funded an organization of very nice people, but who knew nothing about Milwaukee and knew nothing about the population. So we have a young white lady, girl, I call her a girl because she's a lot younger than me. But she was asked to come to speak at a black church about the ACA and about what was going on with it. Just so happened one of my staff members went, and good thing she did, because I think she helped her get out of the church without getting killed, because she started listing all the things about ACA, and as we all know, the fact that certainly from a health perspective, it's either age or it's tobacco use. Those are the only things by health, but it was listed from the Office of Commissioner of Insurance, and it said geography. And so she had gotten a canned PowerPoint presentation from the Office of Commissioner of Insurance, didn't really understand all of it. So when she said, well, geography is going to be where you live, it instantly went to the people in the inner city of Milwaukee that they're talking about redlining. Oh, so we got to pay more insurance because we live in the inner city. She didn't realize what she said. She didn't know how to take it back. She wasn't even sure if that was right. People got extremely upset. And so Clarine, the person who works with me, she stood up and then tried to explain to them, which she was able to do. I use that as an example of how something innocuous can actually cause a lot more problems, because certainly since we've been doing this, we spend more of our time disclaiming myths about the ACA than getting the information out. The information, and I think most of you probably know that misinformation travels a lot faster than the real information. And so we have to deal with that all the time. No, you're not going to go to jail if you don't pay the penalty. No, you don't, there's not going to be something that happens to you. You don't have to take any doctor you want to take. But what happens is that people need to know the message and the messenger. Both are extremely important, especially with populations who are more marginalized, who don't get the information they should get in the first place, who have been, for all intents and purposes, for the best intentions, victims sometimes of the system that now wants to help them. They don't trust that. They don't believe it. So they want to hear from somebody who can help them figure out what's going on and what that means. So for that reason, we know in terms of who we work with, and like I said, we've been around 25 years, so we know Milwaukee. We're very well respected in Milwaukee in terms of our ability to get information out to our communities, to have our communities come to, because we have community workshops, we have community forums all the time. So this was just another topic that we could bring, and we've been doing that. But we switched this around a bit. We go to where they are. So I was thinking about where I was this time last Thursday. I was at the rescue mission, which is a homeless shelter for single men. because I'd been there the Thursday before I went there, and I did the education and the information on the ACA. And then we went back a week later, and then we enrolled 77 men in 3 hours. At least got their applications done. And these are men who many of them have nothing that's consistent for them except the inconsistency. So they truly appreciated our spending time, talking to them. Some of them certainly had mental health issues, some of them had other aorta issues, but they all were collective in listening and wanting to hear what was going on. One of the things that's happened with our governor on his goal to be president in 2016, while he didn't do ACA, you see why they kicked me out, okay? Or they like me to stay out, but I always show back up, right? So my version of what I call Walker Care for my governor is that while he didn't expand Medicaid, he did do something that was really very good. And that's one of the reasons why I've been really pushing to get people enrolled before he realizes what he did. But what he did was, Wisconsin's had a 1115 waiver for almost 20 years. And actually, when Governor Tommy Thompson, when he was governor, he started a program called the Badger Care, which was Medicaid expansion. And the Democratic governor after him expanded it even more. And then when Governor Walker came in, he's been dismantling it since 2010. So we actually, not only did he not take the expansion money, he actually decreased it back down to we're only going to serve people in Wisconsin who are at or below the federal poverty level. So, but he is including, that wasn't there before, childless adults. He requested 1115 waiver to include childless adults, which is a major population in our community, especially with a 60% unemployment rate for African American males. So we have a lot of those who are under the poverty level. And so they're not even thinking about that they would be able to be eligible for this, because that usually is not what's there. And I think that's one of the things that if you're working with populations who are marginalized, that's whether they have mental health issues or whatever, or people who work with them, they have to get the right information to understand that this could work for them. So we're telling them now that no, men can be, it's not tied to whether you have a job or not. Well, it's not tied to if you don't have a job. I mean, I taught healthcare financing when I was teaching at Marquette for about 10 years, and I taught a graduate course, and I always explain to people that healthcare in this country is a business. If you understand, it's not social policy. We talk a lot about the policy around it, but that's why the policy around it is so crazy in this country, because it's not social policy, it's a business. And even the way the Affordable Care Act ended up a lot to do with business, with deals that were cut with pharmaceutical companies, cut with the hospitals, cut with by the insurance companies. It's a conglomerate of what happened with that. So I look at its fallacies for that reason, but I'm also still very enthused about whatever we can get, let's take it, and let's make sure that but we need people to understand. We don't want to give people a false picture of this is the greatest thing in the world and it'll work for everybody, because it won't. There are major folks that it will not work for, major groups that it won't work for. And I'll give you an example of a lady who came to me and said that her son, who was diagnosed with attention deficit disorder as a young child, he's 29 now, and her husband and herself had taken care of him since he got off of their insurance. They've tried to get him on disability. He can't get him on disability. They now are retired. They also are divorced, so they don't have the discretionary funding they used to have to pay for everything for him. And so she was looking to see if the Affordable Care Act could help her with that. Now, what happens is that he could, on what I just told you, he doesn't work, so he could fit in getting Medicaid. The problem is she spent about 10 years finding a psychiatrist that he could relate to who doesn't take Medicaid. So she's like, well, do I still have to, she has a separate policy for him, pays $460 a month. Now that's supposed to go up to $495 at the beginning of next year. So she has the thought of she could get Medicaid over here, but she has this therapeutic relationship with the psychiatrist over here. What does she do? And those are the kind of scenarios that I've been dealing with day by day. And it's not just as simple as how do you navigate through the system. People have a lot more questions on that. And that does say something, because yes, you have access increased, but please remember in 1965, that was the mantra when we got Medicaid in the first place, that it increased access. And it did increase access, but also create a separate, for lack of a better word, a separate, subsystem. And certainly a subsystem that's viewed by many practitioners, and certainly within mental health, that's there as well. You have many health practitioners, depending on where they are, will not take Medicaid patients. That has to be thought about, and I think, and obviously because it's a state and federal run program, it would vary in different states. But for folks to say, oh, this is great, I can get in now, I can get this, but then when it comes down to their daily lives, how do they begin to do that? This woman is just an example of some of the questions that have come up for us in terms of how do we get people enrolled. But the subtext of that, though, is that they still want to do it. They just want help to figure it out. But they didn't even know what was going on until we came out and started really getting everybody a lot of information. So whether I'm in an audience like this, where I assume most of the people in this room have insurance, but I tell them, but I guarantee you that also most of the people in this room have brothers and sisters and nieces and nephews who don't have insurance. So not to turn their ears off because they think it doesn't affect them. And I can see some folks, especially when I go to black churches, they're like, oh yeah, I know this one. Let me see if I can get him in. We're not getting them to think about the fact that they can get somebody else into care, but what does care mean is going to be very, very different. And as an advocate, it's important for me that we're true, that there's fidelity in what we say to people, even if it's not good, that they get the information. You'll find that people appreciate that a lot better than things being folded over. I hopefully that because you're looking at your policy people and you're looking at policy, think about what's going to happen within your states around this issue of Medicaid and the exchange. It's stark for us, again, not like Liz or Dr. Brent, because your stuff is all done through the state. Ours is out there because we have a federal exchange. So you have people saying, okay, now I got to go to the state, I got to do this. Are they going to do that? It makes it almost so much to the fact that people will begin to back off and not want to participate at all if they don't feel they have somebody out there that can champion what they do. So what I'm suggesting is that one of the key components of enrollment is having a champion. You need to have somebody that champions what this population needs, because many times, especially their families, as Liz said, are wore out just taking care of their family. But many times, providers and policy people don't necessarily become champions. I mean, you're good at writing policies, but then when you got to move it down to my level of policy to program to service delivery and what impacts that service delivery, I sit there sometimes and I wonder, oh my God, what were these folks thinking? I think back to my old critical care days. I went to go work in the VA hospital and I was working in a surgical ICU. Brand new, beautiful surgical ICU. I was being orientated to, and they had these towers where everything was on these towers that you could use to take care of this critically ill patient. But when they were orientating me, they were steady bringing out different machines, hooking it up, and I just finally said, how come you're not using the tower? And they said, well, when they designed it, they didn't ask any of us who used it, and it made it so they couldn't get the bed all the way up to the tower. That was the bottom line. I think that happens too often when you're in silos and you don't get a chance to hear what people, in terms of that boots on the ground, hear about what's going on. So I would encourage that you continue to look at some of these things as the policies. This is good, I'm all for it, but I'm also probably going to be your worst nightmare in terms of asking you, okay, now what? This is happening, how do you do that? So thank you for inviting me. I probably won't get invited back again. I think I might. But thank you very much.
All right. So, well, I think before I dive into the questions, I feel that the panel deserves another round of applause. That was really wonderful. Thank you. We really appreciate you all taking the time to prepare your remarks and think through how we all can take next steps as a group and as a community to do everything that we can to make sure that enrollment is a success through the Affordable Care Act. So I have a number of questions. Are we collecting more, or am I just, no? Okay, so if you have other questions, please put them together with the baskets and we'll get them up here if we have some time. So the first question, and I'll throw this out to anybody on the panel, there's some interest in if anybody has experience with an effective outreach program that really targets people with serious and persistent mental illness. Is anybody aware of an effort that really tried to reach folks with serious mental illness? And if you do, please describe.
I'll start. I mean, basically, one of the advantages of the history that Dr. Sharfstein shared earlier is that individuals who are uninsured and have severe mental illness, since the 60s, there's been a process of trying to get them into services. So in many ways, the outreach is already there for the serious and persistently mentally ill who are without insurance, because they have been in the public mental health system. And especially over the last 10 to 15 years, there's been an effort to move those individuals into entitlements. There's been this movement towards trying to get people into Medicaid or SSDI. So I think that the effort preceded the Affordable Care Act and actually made it easier for us to work with that population and move into the Affordable Care Act.
So, go ahead.
So there's two different things I would actually mention, and Liz can speak to one of these. There's an organization in Portland, Oregon called Central City Concern, and a lot of my examples come from Oregon because that's where I've spent most of my career. So Central City Concern was a group that we reached out to actually at Healthy Kids when I was running the Medicaid and CHIP program there for the outreach. And although they serve adults, one thing that we found is they do a tremendous amount of community outreach. So they have a health clinic, they have a housing program. They're an amazing organization. And what we found was by working with them to at least spread the word through their caseworkers, and this involved working with the executives of Central City Concern to move the message all the way through their organization, because the majority of folks at Central City Concern really didn't need to know either about Healthy Kids or moving forward about how to do application assistance. But what they did need to know was if any of the folks they were interacting with had kids, we wanted them to be able to spread the word that there was a program they could apply for. And I'm not sure if they're playing a role with Cover Oregon currently that you can speak to. So I'll turn it over to Liz to talk a little bit more about that. And I also want to suggest that SAMHSA put together a lot of resources which Kevin can discuss, but at Enroll America, we're continually looking for these concrete examples to share with you guys. So SAMHSA has tremendous resources, and Central City Concern has done some great work.
So I was just going to mention that one of the things that Oregon has, we're incredibly coalition rich. So there's a coalition that works with organizations like Central City Concern, which does housing, medical care, mental health, behavioral health. They do just kind of a really broad base of services to the clients that they serve. But they are connected with like the emergency rooms in the hospitals. They're connected with the public safety and police departments. They're connected where it is that folks show up when they are in crisis. So when I think of the question, which was really about, I believe, about people with severe mental illness, what we've tried to do is to create a network where there's an access point for where they might access, as opposed to creating one centralized place where we're trying to get them to come to. But we've got a pretty good, rich network, and I'd be happy to connect folks with them if that worked.
And we have, actually, we have one of the few states yet that the primary entity that you call when someone is having a problem that's severely mentally ill is the police. And actually, we're trying to get that changed, because what happens is they end up in jail most of the time, unfortunately. And actually, we actually have a program. We work primarily with pregnant women in the jail, but we're broadening that now to enroll anyone that's in the jail, but that shouldn't be where they are. But unfortunately for us, that is where they are, or they're at the mental health complex itself, which again, then they're in intensive inpatient care and basically drugged up and out of it, to put it very bluntly. Makes it very difficult. But for someone who's looking for something that you really got to figure out what you've got and then see what you can do with that. But even with that, we also do have programs, intensive case management programs, where they will go to the homes. They'll do medication treatments in the homes. They also are looking at having those, making sure those folks are signed up for services to get them. So you got to be real creative, and wherever you meet them is where you want to make sure that there's someone that can get them enrolled.
Excellent. I think the only couple things I wanted to add to that was the SAMHSA has, through the SOAR project, added another module, which the SOAR project, if you're not familiar, does focus on SSI, SSDI eligibility. But going forward, there will be an additional module focusing on coverage enrollment as well. And I also wanted to focus on some of the work from Healthcare for the Homeless in Baltimore. They've done a lot of excellent work on targeted outreach to persons with SPMI. And I also wanted to take a moment to give a shout out to Mental Health America that has received some of the Navigator grants. Debbie, if you want to raise your hand, if you want to talk to her afterward about some of the work they're doing on this issue, I encourage you to do so. All right. So on to the next question. I think this is really going to be a good one, Dr. McManus, for you to highlight as well, but others think that your story about the faith community was right on point here. Someone asked, what is the role of the faith community that people have seen in enrollment to date?
Well, I know in Milwaukee, what's been happening is that they've been reaching out. Milwaukee has done something, I think, pretty well in their overall health arena, in that they have been reaching out to faith-based, especially within the African-American and Hispanic communities. And so they've already got other health programs going on already, looking at infant mortality, looking at, trying to get people to stop smoking, looking at other things. So when this came up, actually many of those faith-based organizations actually started calling us about participation in getting information in terms of enrolling people. So I would, again, if you don't know personally, it'd be good for you to have a link to those organizations that have that relationship with the faith communities. Sometimes folks will go and say, well, let me just go see if I can talk to that person and see if I can get in. I mean, the faith communities, they have their culture like everybody else, and you can't just walk in there and say you're going to say something. But if you have that linkages already, I think that's probably the best. And then they tell somebody else, and they tell somebody else, and that's why I really haven't slept in the last 6 weeks. Because Sunday, I had told my own pastor, I'm not going to be at church today because I have to go over here and enroll some people, some other church, and he's looking at me like, okay, that's you, so I know that's what's going on. So, because you got to be, if it's in the evening, this can't be a Monday through Friday thing, especially with churches. It can't be Monday through Friday. I mean, if you got that whole taking souls to the polls, then you also know that even people enrolled, you use the same model and get people enrolled. But it's got to be done by folks who they trust.
And if I can just jump in, so our national campaign, Get Covered America, just put together a toolkit of how to do faith outreach. It's called Healthcare from the Pulpit, and it goes through how do you make that introduction? What is that step-by-step process? What terminology do you use if you're not coming from that faith? How do you address it? What should you wear? What kind of options can you provide? What ways can people get involved? So you can find it at getcoveredamerica.org, and it's a whole toolkit that you can use or your organizations can use to do faith outreach.
I think the only other thing I would add is that the White House Center on Faith and Neighborhood, Office of Faith and Neighborhood Partnerships has been really actively working with their network of somewhere in the 20,000 faith leadership community across the country, trying to share information about enrollment. But I think that a key takeaway for me, Dr. McManus, and from your comment as well, Jessica, is that it really comes down to that relationship. You know, having even information coming from outside that person doesn't understand necessarily is really not going to be the same as having somebody from the community who knows them already. And we found some of the same things with our research around enrollment assistance for people with mental health and substance use disorders, is that across the board, peers, providers they already have a relationship with, are way more effective than anybody new in that conversation. Excellent. Next question, and I think that this is something that people did address at some points in their presentation, but it's definitely worth noting, is regarding people who would be eligible for coverage under Medicaid expansion but who are living in a non-expanding state. What can we tell them?
I'm sorry, say the first part of it.
So
I think
it's
I
people.
said I wasn't thinking of sex though, but I did. I veered off for a few minutes. I second that. So repeat it, would you please?
That was wonderful.
Yes.
So the question, pardon me, is jargon rich, as I am prone to. The question was, in states that are not expanding Medicaid, people that are below the poverty line, thus they're not eligible for tax credits, what do you tell them?
Well, ours isn't below the poverty level,
So I
so
think-
we're good. So maybe.
I don't know if there's anybody on the panel, except for maybe Jessica, who's been in the situation of
You go first. I mean, I have.
I have an idea as well.
Yeah.
Yeah. And see, ours isn't.
So a majority of the states that we actually have staff on the ground in have not decided yet to do a Medicaid expansion. And this is a really hard question that there's not a great answer to. What we're finding when we're talking with consumers, and I think this is an important point, what we're finding is when we're talking with them, we actually don't know what they're eligible for. And people automatically weed themselves out. So if you think about those 4 facts that I put up there earlier, right, that saying that coverage is available, it's going to cover all the care that you need. It may even include these. There may be financial help available, and letting them know where to go to apply. That's the message that we're giving. And when you are talking to a consumer who either isn't going to be able to get that coverage or for some reason can't afford that coverage, what we want our folks on the ground to know is where those consumers can go for help. Because regardless of whether or not they are in a state that has a Medicaid expansion, they could also be a mixed documentation household. They may not be able to afford those coverage options. So letting people know that you can go to that local health center, that there's other resources available in your community, and not necessarily weeding people out because there's going to be a gap, but they could be in that income level where there's already a program available for them. So rather than focus on you might not get something, we're flipping it and saying coverage is available, go ahead and apply, because we don't know if they're going to be able to get something. And here are the resources locally where you can get services.
And that is true. We've been doing that as well. A lot of times people ask questions. I mentioned before the difference between the Medicaid and what happens with the health exchange. And what we do is just tell people, I really just tell people, just apply. Don't, because you don't know and you can't get the answer. Because some people just say, well, I want to know how much I got to pay right away, even if they feel they're going to be eligible. And so even those folks, we say, just apply, just see what's there. And then like Jessica's point, we were referring people to other, because we do know most of the other resources that are in the community in most areas. So then we refer them to the free clinics, to the qualified health centers, to the other places that have the mental health. We work real close with NAMNI in our city. They have a very special African American outreach program there. So we refer them to those parts, because at that point anyway, there's not a lot that you can do if the state is not going to do it, but it doesn't mean you can't still provide some services.
Absolutely.
So I just want to, maybe it's an opportunity for advocacy. I know that the Center for Budget Policy and Priorities, which is based in Washington, D.C., actually has been actively trying to get HHS to change the rules around what happens between a state's Medicaid eligibility and 100% of the federal poverty level, and this is very wonky, I apologize. It's partly based on the fact that the ACA language says when the subsidies start.
At 100%.
At 100%.
Right.
And so there actually has been some pretty massive discussion about if a state is not expanding Medicaid, can somebody be eligible for the subsidies at $1 over the Medicaid eligibility, to basically have the rules drop down to the Medicaid eligibility in that state. That is not a dead issue, so if there's something you want to advocate for, I think that's an incredible, tangible thing to advocate for.
Excellent. I think the only thing I would add to that is that definitely to encourage everybody to apply. because you don't know what you or your family might be eligible for. In some cases, we've definitely heard of folks that are uncomfortable necessarily putting in their personal information before they know what they might be eligible for. And I think there's some great resources, including actually at Enroll America, where you can put in information that's not a government website that will help give you information about what you're eligible for people who have that concern about sharing that sort of income info.
And Kaiser has that too.
Yes. And then the final thing about people below the poverty line is related to people who are documented immigrants. In the 5-year waiting period, they are eligible for tax credits and cost-sharing reductions if they're below the poverty line, only if they are documented immigrants in the 5-year waiting period. So that's a sort of another little island of coverage in the storm. There's actually a question on sort of building off of that subject that may similarly draw upon our knowledge about other safety net services, and it's about people who are undocumented immigrants and what we're able to tell folks, what we do with regards to application counseling when we find out members of a family may be undocumented, and what we can do in that situation. And I think just to say out front that they are not eligible for coverage under any of the programs from the Affordable Care Act, but I think it's helpful to talk through what we would say, what we can do to respond to people who come to us in those scenarios.
Exactly. I think certainly part of that is talking about the other services that you know that are available. I think mental health services, again, that's harder than just physical health services, because for people who are having some kind of mental health crisis, whether it's depression all the way up to, full psychosis, it's so culturally dictated around how people respond to mental health issues. And then if they can't get in to see someone, so if you don't know someone already, you really have to make sure then that you know where the providers are that are willing to help right away. And like I said, that's where we use NAMI a great deal. I'm on the mental health task force in our area, so that helps too, because you have that whole coalition of people who can get things done. But a lot of times when you're trying to help people in other areas of health, if they got someone in their family that's having a mental health problem, but also is not eligible for any services, and clearly they are very reticent to go any place because they think they might get turned into immigration. So it really is a trust thing again, and certainly for a lot of those populations, and our working with the Hispanic community, they tell me that in terms of at least trying to get maybe them to work with the priest who's ever in the area, because they will trust them on some level, so you have to know those nuances of how you work with that.
That's very helpful.
I was probably going to echo some of that. I think that it's part of the reason that we've invested in the use of community partners, again, where folks would naturally go to ask questions and to look for help to support, that's the place where they can come into the portal. But the other thing, and again, I don't know this for other states, but because Oregon has an inside the exchange and an outside the exchange market, that we just want to make sure that folks understand inside the exchange is not the only way that you can get coverage, and that you can still get coverage and not have to do the federal application and do all of the things that are inside to get the tax credits. But that's really where we are depending on people in the community and with community organizations to help both get the word out and to help people navigate what those options might be for them.
I would just add that it's not infrequently when you're talking about documented and undocumented, you're talking about in the same family. You can have the parents who are undocumented and the children, because they were born here, are documented. And yet there may be a fear on the part of the parents that if somehow they sign their kids up, that it would come to light that they're undocumented and they could end up having serious problems with immigration. And that, depending on what state you live in, that may not be a paranoid idea. That may actually, there may be some reality to that. So I do think it goes back to what was mentioned before, that relationships are very important. Working on those relationships and trying to develop the trust to get the families to sign up. And also when you're talking about individuals, again, with serious mental illness, we have a tradition of providing a safety net for the uninsured. And that's something that as we move ahead with getting people on entitlements, we don't want to lose that safety net, that there will still be a group of individuals who are uninsured and severely mentally ill that are going to need that safety net. Not everybody is going to be on Medicaid.
Hear, hear. All right, that I think is a really important note to finish on, Dr. Hepburn. Thank you. And I think we are out of time for the first panel. So I think please join me in thanking our panelists again.
So you folks can either stay here or take your seats in the audience, whatever you prefer. But hi, I'm John Bartlett, Senior Advisor to the Mental Health Program here at the Carter Center, and we've reached that point in the program today where we turn the issues over to you, namely the breakout groups. And so my job is really to deliver the charge and then dismiss you to the various locations around the center where you're going to be doing your work for the next 90 minutes or so. But if I could just digress for a little bit, I want to point out that it's exactly 20 years since I first stood on this stage. I was honored to speak at Mrs. Carter's 9th Mental Health Symposium on quality. And I don't remember very much about the comments that I made at that meeting, but I do have two enduring memories of it. The first is the graciousness of Mrs. Carter, who profusely thanked me for coming from Minneapolis to speak at the meeting 2 weeks after the birth of my baby daughter. And I assured her that I was happy because the night before I'd gotten the best sleep in the hotel that I'd had in 2 weeks. And the second memory I have is of this tall, debonair Southern gentleman who was moderating the symposium, and the energy and gusto with which he delivered the charge and dismissed the audience to the work groups. And that really stood in my mind all those years, and I had subsequently the opportunity to see him on many other occasions do the same thing. That was the late Tom Bryant, and he was really an important part of the symposium for many years. So I just want to acknowledge the fact that I know I stand where a giant once stood in delivering the charge and dismissing you. And by the way, he was a lot taller than I was too. So now on to the charge. We have 4 working groups. We've based them basically on regions, and that was because the Affordable Care Act is implemented at the state level. We couldn't have 50 breakout groups. It just wouldn't work. We don't have the space. So we've divided you regionally. It's probably a good idea to identify who else is from your state, except for there is a Georgia group, and you're all from Georgia. So there are one breakout session today for about 90 minutes. There are 2 breakout sessions tomorrow, one after another, and those are about 75 minutes apiece. The breakout sessions parallel the plenary session. So the breakout session today is devoted to the question of outreach and enrollment. What we'd like you to do is we'd like you to identify 3 issues, 3 ways to improve access and delivery of affordable, appropriate behavioral health care under the Affordable Care Act. And the recommendations from your group, that's up to 3 recommendations. Recommendations today should focus on the area, again, of outreach and enrollment. Tomorrow, the first set of breakout groups will focus on the issue of access. The second set of breakout groups will focus on the issue of service delivery. The recommendation should be actionable. So when you make your recommendations, consider the tools and the information, the data that would be needed to promote and implement and monitor the implementation of the recommendations. Think of the obstacles and barriers that will need to be overcome. And finally, think about what entity or entities should have responsibility for the implementation so that there's some accountability. One of the first tasks of the moderators, by the way, should be to select a scribe who will take notes on the flip charts. Now, we do have recorders in the meetings that will be taking notes, but the flip charts are incredibly important for the summary meeting session tomorrow afternoon. So we'll need a scribe in each breakout group who will volunteer to take notes on the flip charts in the rooms. Find your group listed on your name tag, or there is actually a list in your packet. Take your materials with you. We're not coming back here, all right? We're not coming back here tonight. We won't be back here until tomorrow. No, you'll be back. The working group meetings end at 6 p.m., and the reception and dinner is to follow. Volunteers will be posted throughout the center to help guide you, and each group will be led by one of the mental health program interns or associated interns who will also participate in that group as the recorder. The museum will be open at 6 p.m. Admission will be free, but there's no food and drink allowed in the museum. So you have to sort of make a decision between, am I going to have that glass of wine, or am I going to go in the museum? You can't do both at the same time. We're going to dismiss you in the order of the furthest group away, and that is Group 3. And Group 3 will be moderated by Eve Bird and Daniel Dawes, and you'll be meeting in the Copenhagen Cafe. Now, that's the furthest away. It's way over on the other side of the center. The good news is that you're closest to the bar and the canapes at the end of the 6 o'clock. So, so if you could get up now, go out, audience, what I call hall left. This is Group 3. For those of you coming down from the balcony, you can meet them at the bottom of the stairs. And we'll wait while they get organized and get off to their task. Libby, would you make sure that they know there are people coming down for Group 3 down the stairs and that they get over to... Okay, Group 1. Again, check your name tag or check your name on the list that's provided in the packet. Group 1 will be moderated by Leslie Scallett and Bill Emmett, and it will meet in the rotunda. Again, through the double doors to your left. All right, let's move to Group 2. Group 2 will be meeting in the Zabin room. It will be moderated by Ruth Shim and Glenn Stanton. It was a lot taller. So that leaves group 4. And group 4, you're going to stay right here in the chapel. But you have the longest walk at the 6 o'clock hour. Group 4 will be moderated by Pamela Greenberg and Donna Mosh. Okay. Apparently, if you're in group 4, you're supposed to be led out of the room and then you'll come back in. I'm not exactly sure why that is, but we do what we're told. So if group 4 could follow that lady right there with the sign out of the room, maybe there's some cleanup that needs to be done. Maybe it's a mystery.